a lot of time working with families facing adversity and crisis in my work in child welfare, where they were confronted with a lot of adversity and stress, poverty, substance use, family violence. So I have a real deep appreciation for the challenges that come with working with families that are facing a lot of stress and how to kind of stay the course while also managing some of these other issues. So welcome, and thought what we would do is talk a little bit about the plan for today. First, I just want to frame the issue around what's considered best practice when treating families in an evidence-based way, and then I just want to distinguish, just kind of remind us all about when we're talking about stress kind of more generally versus post-traumatic stress as a clinical disorder, and then talk a little bit about screening for trauma symptoms to help clarify the clinical target when working with families who are stressed. And I'll talk kind of more broadly also around assessment and how that can be really helpful in honing in on kind of knowing where you're starting so you know where you're going, which I think with families who come with a lot of, who are really overwhelmed, that practice in and of itself can be really helpful. And then I'll wrap up with addressing how family adversity or psychosocial stress can get in the way of using evidence-based practice, and talk about some strategies and approaches for staying the course with EBPs, even when faced with families who present with a lot of challenges, in addition to what's bringing them into treatment. And I think it's worth acknowledging here many concerns that clinicians voice, and perhaps some of you share them, those of you who are on the phone, that youth in the real world, they do differ from youth in studies of evidence-based practice, that they have more disruptive behaviors, more socioeconomic stressors. But research still shows that the effects of evidence-based practice are stronger than treatment as usual, even when you consider all of these factors. So I definitely want to acknowledge the challenge, and that there's a lot of additional factors to deal with that in the real world. But it doesn't mean that evidence-based practice should be abandoned altogether. Hence why we're putting on this webinar and going to be having our consult calls following in the weeks coming. I also want to just say that I'm not offering a magic bullet, unfortunately, and that there's just a lot of persistence and creativity that's required in working with families facing adversity and crisis. So what I'd just like to hear from folks now, in terms of thinking about your cases, what currently derails you or gets in the way of, for you, implementing evidence-based practice with a client or family? So what do you see as getting in the way of you being able to do that and feel successful? So we'll just give you a chance to write in. There should be a place for you to write in your responses in the question box, and then we'll be sort of looking at those. I see that we're getting some responses. It looks like, I don't know, it looks like all of you maybe are at one computer, which is great because it looks like it's one person, but I just want to encourage, but it could be that there's lots of other people sort of contributing to that. So I just want to encourage everybody to offer their response. Okay, so it looks like here are what, thank you everybody for responding. Some things that get in the way are family violence. Looks like family members who appear to be on drugs during the session. Families who won't let you in their home, consistent no-shows or canceling, the culture of poverty, custody issues, unengaged, unwilling parents, stressors from living in rural areas, another substance abuse, multi-generational substance abuse. Great. Well, thank you. Thank you for all that. And I think those are ones that are consistently faced by clinicians. So I'd like you to think about your cases and think about those challenges today as we are going through this webinar. And then I'd also like you to be thinking about these if you were reflecting on specific cases, to also bring those to the consult calls. And I'm going to talk a little bit about the consult calls at the end of the webinar today. So I think that it's important to start this discussion off with what's considered best practice when that applies with working with all kinds of families and clinical targets. So first we want to enhance motivation, and I think this gets at to a lot of what you identified as barriers, unwilling, unengaged parents, certainly families who won't let you in the home. That is very, it's hard to do anything if they won't even open the door to you. A lot of no-shows or cancellations, those all speak to this issue around engagement. And I do think that families who are facing a lot of adversity and psychosocial stressors, that you do have to put a lot of front-end work in on engaging and enhancing motivation. A lot of families, I think particularly families who have maybe been in treatment for a long time, or like I said, are facing a lot of stressors, have had a lot of negative past experiences with mental health or other agencies that would be described as like helping organizations. And so a lot of times we as clinicians are having to kind of make up for, we're not only having to do the work that we're trying to do, but we're also having to make up for all those other negative experiences, and that what the family is sort of bringing to the table is not just their current problems that they're wanting help with, but these maybe ideas and notions around what therapy is. Perhaps they've been blamed in the past for maybe their kids' problems, and they're anticipating that, and so they may appear to be unwilling or disengaged from the process, but really they may have a lot of ambivalence or skepticism about how you can be of help and how treatment can be effective. And so I think really keeping in mind how this first encounter with families is an opportunity to help them feel acknowledged and validated for what they're going through, and to instill some hope that they can get the help they desire. We do know that negative experiences from past treatment is very predictive of dropout, or of this kind of no-show coming once in a while, then no showing, canceling at the last minute, that kind of thing. So I think really thinking about focusing on acknowledging and validating, that they at least took a step to get some help, that they took some step to that they're showing that they care for their family. This is also a good time for me to tell you about another webinar that we're doing. Sorry, it's not a webinar. It's an in-person training that EBPI is offering. My colleague Jessica Leaf is going to be talking specifically on engagement and enhancing motivation with families. So I will give it some coverage in this webinar today, but certainly will not be able to go into the level of detail, and really encourage you to stay tuned for that. And if you can participate in that, I think it's going to be really helpful, because that's an issue I think that really requires a lot of attention. So like I said, Jessica Leaf is going to be doing that in person. You should be getting some information about that. So the next, and engagement is not something that you just do with the beginning. It's kind of an ongoing practice that with a lot of families you're sort of continually having to engage, maybe sort of, at the start of every session to do some engagement to sort of get their recommitment to treatment. Assessment is the next part of best practice. It's really the cornerstone of all effective treatment. And as I was saying earlier, that you can't really know where you're headed if you don't know where you are in the first place. And I want to link the engagement piece and the assessment piece, because assessment provides a really rich opportunity right up front to engage families who are facing a lot of adversity and stress, and that by asking them and finding out what are they saying is the problem, and then the second piece to that is giving them feedback on the assessment results, that by giving them feedback really lets you know that you are listening to them and allows you to be able to acknowledge and validate their experiences, which is really part of that engagement piece. So assessment, I think sometimes view it as, oh, we have to get all this paperwork in and get our boxes checked, but really want to encourage you to think about assessment as not just certainly a valuable information gathering tool, but it also is a way to hook people into treatment. And then, as I said, assessment allows you to know where you're at and helps you to identify the clinical target, so you can then select the most appropriate evidence-based practice. So once you know, again, you have a target, then that allows you to, we have, the good news is we're at a time where we have a lot of good information about what is effective for a lot of children's problems, and that you can see a lot of good results in a relatively short period of time for, like I said, the majority of what kids present with to mental health organizations. So while evidence-based practice can help to target symptoms, to help improve family functioning, can work to buffer from future stress, to promote positive coping, promote resiliency. No matter how effective it is, it's not going to solve every problem for every family, and it shouldn't be considered a panacea. Some children are brought to therapy to address behavioral or emotional problems, even though there are more pressing problems in the family or environment that cannot be addressed through child psychotherapy. It's unfortunate but relatively common for us providers and for other systems we want to recommend a lot of services to troubled families in the hope of addressing their myriad problems and needs. For example, in the child welfare system, parents are often expected to attend parenting classes, substance abuse treatment plus meetings, anger management interventions, personal therapy, as well as take their children to counseling. And that family may, in addition, be on the verge of homelessness. They may not have access to adequate child care, and they may be struggling financially. It kind of gets back to the, the culture of poverty. And in this circumstance, it's not reasonable to expect parents to devote the attention and effort that effective therapy requires from clients. It may be most helpful in such situations to help the family and the referring parties to prioritize and triage services to the family with maybe an initial focus on stabilization of housing and finances, and then be able to address the other issues around behavioral problems. So it's important to communicate clearly to families and systems what therapy can and cannot achieve, and that it would be great if we could, it's not to say that we can't work with these issues of stresses from living in rural areas, of custody issues, of poverty, of substance use, but we may not be able to, we're certainly not going to be able to in our work like overcome poverty for them, unfortunately, but we can be aware of that and look for ways to recognize that and how we can continue to, if we can, help a family with one particular area, that it might alleviate a little bit of stress or help them out enough to be able to deal with some of those other ongoing challenges that they're facing. So we're not going to be able to solve all the problems, but if we can really help them to sort of feel like one area they have some competency and mastery in, that it would hopefully spill over into other areas. So I think that's important to keep sight of. I wanted to run down briefly some of the characteristics of evidence-based practice that actually align really well when working with families in crisis, that there are some advantages when working with stressed families that the evidence-based practices have. I've alluded to some of these already, and I'll be talking about them throughout, but I think there is some advantage that there is a targeted focus of evidence-based practice, kind of what I was just speaking to, that allows you to hone in and help a family in one particular area, so maybe other things feel less overwhelming. The nice thing about evidence-based practice is that they're really intended to be time limited. And so families who do have a lot of other things that they're dealing with, that we're not expecting them or wanting them to be making sort of therapy this ongoing kind of extracurricular activity, that if we can really target symptoms and problems, and again, this also assumes that they're engaged enough that they're participating in treatment, that it's really intended to be time limited. And then the skills, I was saying, the skills they may learn for one particular clinical problem or clinical target can actually generalize and be applied to other areas of their life in which they're experiencing some challenges. So even though there is one particular target or two targets, a lot of these skills transfer over. Another nice thing for families who are feeling really stressed and may not have a lot of support is that evidence-based practices are really meant to be a collaborative and transparent process. That they're, and this is, I think, goes again back to some of the engagement aspects, that talking up front about what treatment is going to be working on, clarifying any misperceptions, answering questions, asking them, getting their input, giving them feedback on on the intake information, on assessment results, really helps to establish this collaborative relationship that hopefully can set the stage for future work. These are just some examples of evidence-based practices. that have been shown to work with families facing adversity and stress. Again, this is not a comprehensive list. It's just some examples. Trauma-focused CBT, alternatives for families, CBT, that's one for physically abusive families, functional family therapy, and then triple P is addresses disruptive behaviors in children. There's a particular level of triple P that addresses some of the stressors and families maybe at risk of maltreatment. A nice resource I wanted to just point you to is some of the feedback that we got. Some people were interested in not just how to implement EBPs with stressed families who are dealing with a lot of challenges, but some may be interested in just how do you go about selecting an EBP and sort of implementing that more on an organizational level. So this is a nice resource if any of you at your organizations. It's through the the Evidence-Based Clearinghouse for Child Welfare, the California Evidence-Based Clearinghouse for Child Welfare. So even though it comes out of California, that just reflects who's kind of sponsoring it. But you can type in, the nice thing is that you can select, you can type in a program and see what it's rated in terms of evidence-based, research-based. You can also find out about assessment tools. It's really a wonderful resource, but this particular link takes you to a PDF. All right. So oftentimes the word stress and trauma are used interchangeably, and we talk about families dealing with a lot of psychosocial stressors or adversity as being traumatic or dealing with trauma. And while certainly having a lot of stressors is very distressing, and in fact there are some families that are dealing with both a traumatic event and also experiencing psychosocial stressors at the same time. Maybe the stress was prior to the traumatic event or is being exacerbated by the traumatic event. However, clinically, it's important to distinguish between stress and post-traumatic stress and to be clear what is meant when we use the term trauma versus stress or crisis, chaos, adversity. Stress can occur at multiple levels of a family's ecology, at the child level, at the family level, community level, at a system level. Here are some examples. Poverty, family dysfunction. So again, we talk about, someone had wrote in about the culture of poverty, certainly a profound stressor that families live with on an ongoing basis. Not having sufficient social support, maybe in their community, being exposed to a lot of community violence, living in an impoverished community, maybe dealing with an illness, having poor access to care. All these things constitute stress. Whereas when we talk about post-traumatic stress, that refers to a specific set of post-traumatic stress symptoms, which can include re-experiencing symptoms, avoidance of people, places, things that remind you of the traumatic event, having negative cognitions, alterations in mood, and arousal, hyperarousal that may be triggered by an event, and ongoing trauma reminders. You also have to have exposure to a traumatic event, which includes directly experiencing a traumatic event, like witnessing a traumatic event in person, learning that the traumatic event occurred to a close family member or close friend, or experiencing firsthand repeated or extreme exposure to details of the traumatic event, but this is not through media, pictures, TV, or movies, unless it's work-related. So just wanted to clarify, and also to say that it's very common for there to be, when someone's really experiencing post-traumatic stress, that there's also co-occurring mental health symptoms. Oftentimes it's depression or other kinds of anxiety. with that being said, most children exposed to a traumatic event do not go on to develop clinically significant post-traumatic stress, that really the tendency is toward resiliency, and it's about 20% or so of people exposed to a traumatic event will go on to develop clinically significant post-traumatic stress. So on to that distinction. So it's understandable that we might feel like this illustration here, when we meet with families who are dealing with a lot of chaos or crisis or stress, that we're throwing a whole bunch of things at them and sort of hope something sticks. But what this does is dilute the efficacy of treatment and can leave us feeling very burned out, very depleted, not very reinforced for our efforts. So we're putting in a lot of energy and we're not getting sort of the results that we would like to see. So this is what we're hoping to avoid. And so I'd like to take a little poll now. How many, and it should be coming up on the screen. All right, so hopefully you guys can read that. How often do you use standardized screening or assessments with your clients? And so you have some answer choices there. Always, almost always, often, seldom, I don't do this. So I'll pause and let you guys answer that. Okay, so looks like most of you voted. Thank you very much. And it looks like about almost 3/4 of you say often to using standardized screening or assessment, and 29%, so about a third, almost a third, says always, almost always. That's fantastic. That's great. I encourage you to use standardized measures as a regular routine practice with your client. So that's great that all of you are doing often or always, almost always, and hopefully as we talk about this, that it'll just reinforce for you the value of it and to do it as much as possible. So the nice thing about assessment is that it takes out the guesswork, that we can certainly use our clinical judgment, but it's better to, I know I feel more comfortable using assessment and collecting from multiple sources of information than sort of going with just my hunch. But certainly using assessment, we can certainly have hunches, and assessment can confirm or disconfirm that. So one recommendation is that all families, regardless of whether this is the identified referral issue or presenting problem, that all families be screened for traumatic events. It's beyond the scope of the webinar today to go into great depth about this particular topic. This could be a subject for our consult calls if people are interested. But maybe some of you are already doing this, but asking about, because we know that a lot of times people don't talk about traumatic events, they tend to not report them unless specifically asked. And so that's why it's good to be screening all families for them, because you might learn something new that you didn't know before. It also is a clinical encounter, allows you an opportunity to validate and normalize their experience. and to either capitalize on their strengths if they've been able to cope with a traumatic event, or to, again, sort of validate their experiences, normalize their feelings, and to help give them some hope that if they are having problems with post-traumatic stress, that there's help available. So families should be screened for traumatic events, as in terms of establishing their traumatic history, and then also a post-traumatic stress scale to determine if they're having significant post-traumatic stress. Like I said, we can talk more about this. So if there's a traumatic event and they have post-traumatic stress, the good news is that there's a really great evidence-based practices out there for kids who do have post-traumatic stress. TFCBT is probably the most common one, and has been disseminated and implemented very well here in Washington State. The use of other standardized measures to determine the clinical target is also recommended. Measures for depression, behavior, general anxiety. And I think, probably everyone's aware of this, is that, comorbidity, or this co-occurrence of problems, is really the norm, not the exception. So it's to be expected that you will be working with families that are going to be showing elevations on multiple areas. All right, so again, we're wanting to use assessment to pick a clinical target. That can, our assessment allows us to hone in, and like I said, there may be more than one, since the co-occurrence is a very common thing. About 70% of families presenting to mental health clinics will be facing one of the following 4 clinical targets: depression, anxiety, disruptive behavior, post-traumatic, and post-traumatic stress. So it's important, if they're having more than one of these, is to pick a place to start. That can be decided by determining kind of what's driving the train, if you will, sort of what seems to be the problem that's really contributing to a lot of the distress or dysfunction within that family or for that child, what's getting in the way of their functioning, and start there. That's one. What needs the most immediate attention? Maybe it's a child's behavior is placing him at risk for being expelled from school, and certainly the negative implications that could follow from that. And so that may be something that needs the most immediate attention. And it's important to, even with families who are dealing with a lot of adversity and stress, that there's a real benefit in focusing on the clinical target every session and measuring it in some way on a regular basis, through like a progress monitoring form every session, even some scale of 1 to 10. But to get an idea of progress being made. That's also a way to keep families engaged in treatment, is to not only give them feedback at the beginning of the assessment results, but to be sharing with them the results of, as you're giving them standardized measures along the way, to be talking to families about that, and talking about if it's moving in the direction to be expected, or if it's not, that also is useful information into then deciding, do we, what else should be done? Are we focusing on the right thing? Are we doing the right component to get the results that we want? So as some of you had noted earlier about kind of what gets in the way of treatment, you're absolutely right that engagement can be a big issue in staying the course and implementing evidence-based practices. And we know that family adversity and crisis often gets in the way of engaging families in treatment. Family problems have been identified in research as a primary reason for people not completing treatment. And the crisis mode that a lot of families find themselves in can lead to a sense of feeling incompetent, questioning their parenting, and they may be used to being blamed, and that makes them more likely to not come back. So I could spend this entire webinar on just engagement, but again, just another plug for the engagement training that Jessica Leaf will be doing. I think it's important to really keep in mind that engagement really happens at the first encounter, to spend some time learning about the family, how do they see the problem, what do they need. We really want the message to be, we can help with that. There's hope. Important, to look for strengths. How did they, how did they get to where, to get to your office, that reflects some real fortitude in spite of all of the other challenges that they're dealing with, that they're showing some commitment to things being better, to wanting things to be better, and that's a really good place to start. I already mentioned this, but it's worth highlighting again about the value of screening and assessment. So it's great that you folks are using standardized measures on a regular basis, and hopefully with that you're giving feedback to them to engage them. We learn as therapists that one of the ways to build relationships is to use reflections, is to repeat back what we've heard clients telling us, that is a way to help them feel heard and understood, and really to think about feedback in much the same way. It's kind of a reflection exercise, and here's what you told me, but it's through the use of measures, not necessarily through the use of words. So many evidence-based practices take a collaborative approach. So as it's helpful that I think a lot of misconceptions about evidence-based practice is that it stays on one, so there's a rigidity to it, sort of its lockstep. And really, I'd like to dispel that notion that it's really much more flexible and fluid than that. And I think one way is to, with families, especially with families who maybe had some really negative experiences with treatment in the past, is to encourage them to share ideas about how to tailor the skills that you're teaching. So it's not that you're still not sticking with the evidence-based practice elements, but encouraging families to share ideas about how to use these skills kind of in their own personal way. How can they make these work for them? We may have to talk about it in different ways with different families, but that really helps to foster a sense of self-efficacy as well. And the more you can make the link between their stated goals and evidence and the goals of an evidence-based practice, the better. So maybe they want to be able to stand up to family members who are taking advantage of them. This could be linked to improving communication skills through some kind of skills training. Maybe also helping them manage their feelings when dealing with family members that stress them out. Like that could be emotion regulation skills training. So I think the more solid the link between what they are wanting to get out of treatment and what are the goals and objectives of particular practices will be helpful. All right, so time for another question. So how often do you give feedback to your clients about screening and assessment results? So that's kind of what I was just talking about. I'm curious to hear. And by feedback, I mean telling them the score and telling them what the score means, and talking about the clinical target, so if it's depression, kind of what that is, and what treatment there is for that. looks like some people are. I encourage everybody to vote. It doesn't matter what we're not trying to publicly shame anybody. I'm just trying to get an idea of where people are at. I encourage everyone to vote. So it looks like the majority of you are saying you often do this, which is fantastic, which is wonderful, and really ahead of the game on that. So I encourage you to keep that up. I think that will yield a lot of results, and maybe is maybe hard for you to see how valuable that is when families are also dealing with so much other adversity and crisis. But that's really fantastic. Good job, you guys. So when we're trying to use evidence-based practices with families who are dealing with a lot of adversity and crisis, that we don't need to abandon the evidence-based practice altogether. And here I'd like to say something about the therapist-client relationship that, you know, I think a lot of people are concerned that there's some risk of devaluing the relationship by doing evidence-based practice. But in fact, the relationship is very important in all of like the treatments that I had mentioned earlier, and that you really can't do that kind of work without having a solid relationship. So it's research shows that the treatment alliance is not weakened in the context of evidence-based practice delivery, but actually maybe strengthened because of the active and directive and skill-building nature of most evidence-based practices. That there's actually that through that you are building a relationship. Also through that transparency and the collaborative nature, I think goes a long way to building that relationship. And so you don't need to, you can be concurrently building a rapport and building a relationship as you are doing evidence-based practice. And there's research to show that actually doing the evidence-based practice, the aspects, the qualities, the characteristics of that actually will go a long way to building that relationship. So one doesn't have to be put on hold to do the other, that they can occur at the same time and actually should. It's really worth spending time on the front end, making sure that families understand what is the treatment, how it might be different from therapy that they've been to in the past. I think this is particularly relevant. I know when in my work with families that a lot of times parents had the experience of they would drop their kids off to therapy and use that hour for something else. And the evidence-based practices that I were doing actually required active involvement, engagement of the parent. Certainly, if you're doing any kind of behavioral management practice, the parent has to be there every time. You won't get good results without parents being there. But they may have had the experience, not had that experience that their experiences with treatment as they did, that maybe they just chatted with the therapist right up front or maybe at the end. But there's a lot of, so that's important to, so I would have to tell my clients that I was working with, the parents, you know, this may be different than what you've been dealing with before, and this is how it is different. And here's why I want you, in treatment, because you're not part of the problem, you're part of the solution. And that, you know, I only spend a very small amount of time compared to all the other hours in the week that you're spending with that child. And so it makes sense that I have a chance to talk with you and to hear from you to be able to help you with some of the problems that you're dealing with. Same thing with children, that they may have their experiences with treatment in the past may be much different than what you know, I may be doing with them in terms of an evidence-based practice. And so having to, you know, certainly identify what they liked about their prior treatment experiences, but also help them to understand that this may be a little bit different, I certainly try to make it as fun as possible for kids. Evidence-based practice doesn't have to be boring, but to really set the expectations up front so there's no, that's another actually big predictor of dropout, is mismatched expectations from the family and the therapist in terms of what's going to be done in therapy. Highly, highly predictive, especially for minorities, highly predictive of dropout. I think the less discrepancy there can be in terms of expectations and the more in line you as the therapist and the family can be, the better. And I think doing that up front will yield a lot of positive outcomes down the road. So there's also a lot of great fact sheets on pretty much every evidence-based practice out there. We can certainly talk about this on the consult calls too. I have happy to share with you some resources that I have. I think also letting them know about that there's going to be practice in and out of session, that you're going to be asking them these questions, through these screening or progress monitoring forms to make sure that progress is being made. Another thing is you may need to pair other evidence-based practices or strategies with the one you're using. And as I said earlier, that comorbidity is the rule, not the exception. So it may be also, I think, that kind of what I was saying earlier about evidence-based practice not being a panacea, but that it's also, it might be that this particular evidence-based practice is one part of an overall larger treatment plan for a client or a family. So some of you said about substance abuse issues that, of course, we're working on integration of substance abuse and mental health, so people hopefully are going to be going through one door to get both mental health and substance abuse addressed. And so I think that evidence-based practice can be well suited and fit well into a larger treatment plan. So maybe there's some, as I said earlier, some other maybe more kind of stabilization things that have to happen, and then an evidence-based practice can be implemented, but then there may be, once that's done, there may be some other things that family still needs. Maybe it's more communication skills if that wasn't addressed. Maybe it's case management, that kind of thing. So the other thing I think that's helpful with evidence-based practice and dealing with families who are facing adversity is that the skills taught within the evidence-based practice can be applied to other contexts, so other areas of stress or distress that a family is experiencing, that we want those strategies and skills to carry over. So, curious to hear how often do you assign skills practice outside of session? Sometimes we call this homework, although homework is kind of a dirty word. So, but how often are you asking people to do things outside of session that will help them to, that directly relate to what you had done with them in session or a practice component? All right, thank you everybody for that. Looks like we got a little more. Looks like we got a little more variability in this response. About a third of you say you always, almost always. About a half of you often, and 17%, almost 20% say you seldom do this. So that's great that again the majority of you are doing that, and we certainly know that that's a way to help. Again, if we think about, that a lot of these skills, they can, once they acquire them, can use them in other areas and also help them feel like they have a sense of competency and mastery, which hopefully will also carry over into dealing with some other aspects of their lives. So I really encourage you to think about creative ways that you can, again, you don't have to call it homework. I've learned that homework can be definitely a kind of a four-letter word for a lot of families, both children and adults alike. And so talking about trying it out or skills practice are great ways to help people to generalize these skills. So you may need to, with families who are dealing with a lot of adversity, that you may have to expand the modules. There may be maybe to spend more time on certain components. So it's not necessarily that, again, we're trying to just throw everything at them, but if we're, let's say, really feel like this family, we're doing emotion regulation skills training, that it may be for some families, for some youth, that they're going to need more time either to acquire the skills, they need more time to practice it, that it's really worthwhile to, so you may need to do that. Another thing is to bring in, supplemental components. So, ways to decrease barriers. Part of that's that motivational enhancement. That may be something that, just like I said, is a regular part of work with families. Is that you're sort of always kind of getting that commitment, that buy-in. Sort of, talking about, well, asking them to rate how important this is to them, and whatever number they rate, have them talk about why didn't they put it lower, why didn't they make it lower, and have them talk about, so they kind of elicit that change talk, elicit, so they can hear out loud what are the reasons why they're in treatment or why they want, why they're seeking out help. And then we know that social support, inadequate social support, it has been identified by parents as a big challenge, and so looking for ways, again, to do evidence-based practice, but also bolstering social support for a lot of these families who are dealing with a lot of adversity and crisis. I think in terms of sustaining progress over time, as I have probably sound like a broken record, but progress monitoring, measurement is your friend as well, in terms of being able to talk to them about the progress being made, or engaging them in a discussion about maybe progress is being made and then there's been a big drop-off, or a flat line of scores, and to engage in a discussion around maybe what's going on, and to find out that maybe there is this stressor that has come up, and maybe there's be able to incorporate that into treatment, and to be able to address it within treatment. So I think having that ongoing progress monitoring really helps you to, again, think back to our target to stay on track. And then a lot of times, a lot of these families, there needs to be collaboration across other systems of care while you're working on evidence-based practice and drawing on other resources for that. All right, so I think people have heard of cows. They're not just these kind of cute animals that go moo, but cows, or also COD, so crisis of the week or crisis of the day. So these are stresses that can lead to a depletion of coping resources and a real reactive approach to problems. So not just for us as therapists sort of dealing with these cows as families bring them, but also that the families themselves sort of always dealing with these cows, crisis of the week, crisis of the day, can really end having them feel depleted, and they're just always sort of just knee-jerk kind of reacting, and there's not really a consolidation of any kind of skill or use of an approach that's going to be effective. So I think I'm pulling people to death, but I am curious about this as well. How many of you use agendas in your session? So that would be having an outline, having a plan. It can be written or it can be verbally discussed, but an agenda that you review with clients about what the session is going to look like. What are you going to cover? What are you going to do? All right. Well, thank you everybody for responding to that. So what you're saying is, so this is an area, it looks like, compared to other activities that we've been talking about, that less of you are using agendas, about 57% seldom and 43% often. So it seems like it's kind of almost an even split there. And you know, that we'll say we've been doing these other webinars, and that's kind of a similar result that we've been finding. And so I think it's great to know that. And so hopefully for those of you who aren't actively using agendas, that hopefully maybe this will be something that you can incorporate into your work that maybe will help to not feel kind of so overwhelmed. It seems relatively simple, but it's really a great strategy of helping, especially families who come in and sort of want to kind of unload with these crises of the week, is that having an agenda can be a really helpful strategy for keeping on track. So rather than discounting the concerns as a distraction from the real treatment, that you can set aside a portion of the session and add it to the agenda that you can devote to empowering families to take action to resolve these real-life predicaments that they deal with. So it's one item on the agenda that you are respecting it, that you're saying, okay, that's important, let's set aside time to address this, but it's not taking over the whole session and derailing you from your other objectives. So finding a way to incorporate into treatment. So right now, what I'd like to do is, so a client could come in and sort of talk about a stressor, and you know, it could take up the whole session and derail your goals, or you could use it, find a way to incorporate it into treatment. So right now, I'm just going to do a really quick kind of illustration of that with my colleague here. I'm going to be the therapist. She's going to be the client. This is a teenager who's come to session really distressed and cheerful because she learned that her friend was spreading rumors about her and trying to, she thought she was trying to take her boyfriend away. So I'm going to sort of illustrate very briefly how we might do this. So hi, Kathia, it's nice to see you today. I thought I'd talk about the plan for our session today.
I don't think I can. I'm so pissed right now, I can't even think straight. I found out my supposed best friend was talking trash about me, trying to get with my guy.
I'm really sorry to hear that. That sounds like really must be aggravating and frustrating for you. So how would you like to handle this today? We can just talk about it for a few minutes and then get back to our plan for today. Or we could use the situation that you talked about to see if there's any way that you would apply what we've been learning here in treatment. For example, maybe you could tell me, how did you handle the feelings that you had about this friend?
Well, I was super pissed, and I told her to back off and got right up in her face and told her like she had no right talking trash. I mean, she's supposed to be my best friend and have my back. That's just not right. I didn't go to school the rest of the day, and I'm not talking to her.
Okay, well, I'm really glad that you're talking to me about that. It sounds like you were having a lot of feelings about the situation, which really makes sense to me. And I'm wondering if it wouldn't be useful if we put this situation on the cognitive triangle that we've been talking about the last couple of weeks, to maybe make sense of your reaction and maybe identify some ways you could think about it differently. How does that sound?
Okay, whatever.
All right, well, great. So let's put the situation on the triangle. So I'm going to draw my triangle here. Can you tell me, Kathia, what went through your mind when you found out about your friend?
I don't know, I was thinking, like, she's supposed to be my best friend. If I can't trust her, who can I trust?
Okay, so I'm going to write that down here on the thought point of the triangle. That's great. So when you were thinking these thoughts, what were you feeling? And then, you know, that rating scale that we've been using, rate how intense those feelings were for you.
I was mad, out of 12.
Oh wow. Okay, so you were really mad. So 10 is our highest point. So you were super mad. Any other feelings that you were having?
I felt like she let me down as a friend.
Okay. So you felt let down. What number would you give that?
I don't know, 8.
Okay. Great. Well, I'm really glad. I'm going to add that to the triangle here on the feelings section. So you felt let down at an 8, mad at a 12. I'm wondering what you did when you were feeling that way.
Like I told her, like I told you, I got in her face, I started yelling at her, and then just blew off school. I got caught, and now I'm in trouble at home.
Okay, so it sounds like this situation caused some problems for you in addition to feeling really badly and with your friend, that it caused some problems at school and at home.
Yeah, I guess.
Okay. Well, Kathia, you've done a great job talking about this and working through this on the triangle, and I'm wondering if there's a more helpful way that you could think about this situation now that you have a little space from it that might have turned down the volume on some of those feelings. Like, I'm wondering, what might you have told someone else who was going through the exact same situation?
Yeah, I think it would be, you know, like, to just not get so frustrated or like jump to conclusions. Maybe she wasn't really trying to get with my man, maybe.
Okay, so I think that's really good that maybe thinking about it from a different way, that how you said about jumping to conclusions. So if you had the thought like, well, maybe I jumped to conclusions, maybe that's not really the truth, how do you think you might have felt?
I don't know. I probably would have felt different about the whole thing.
Okay. Can you give me a feeling word?
A bit relieved, or like not as upset with my friend.
Okay. So maybe still upset, but maybe not like a 12. What do you think you would give it?
Like, I would understand, and I would probably be at like a 5 or something.
Okay. So so still mad, understandably, but sounds like the feelings would be turned down. Well, you did a great job on that, Kathia. Thanks for working through that with me. And then now, why don't we go ahead and get back to kind of what I had planned for today. All right. So that was just a little, like I said, a little illustration to show how, you know, people can come in with lots of stuff, and that we could have spent a lot of time sort of going through everything. But I had, with that client, that one of the important things is helping to understand the, you know, with a lot of evidence-based practices are CBT, cognitive behavioral therapy, and, you know, a hallmark of that is this understanding the relationship between what we think about a situation, how we feel, and how we act. And so I was able to use sort of this situation that like I said, Chris, a lot of times, you know, she may have just vented the whole time about how upset, you know, how horrible it was, the situation. But I was able to use it, help her to use a skill and apply what we had been talking about with one of these cows. So it's a much more productive way. And so, so encourage you, since and a lot of you are using agendas. For those of you who aren't, it's a really nice way of letting again, talking about those matched expectations, that it's the expectation for the session. It's so everybody's on the same page about what we're going to cover. And if someone brings in a cow, that you find a way to, you add that, you make that an agenda item. You might say, okay, 10 minutes, and then make sure that, that 10 minutes that you've moved on to the next one. You could add it at the end, or as Kathy and I illustrated, to just go right into incorporating that into some skill building. So here are some example agendas that, like, and it can be helpful to write it out. I know some clinicians, like if you have dry erase boards or chalkboards or something in your office, you can just write them up there. You can write it down on your clipboard, or if you bring in notes to session. Verbally, you can do it. Sometimes it is helpful to have it written down, especially if you're working with families who are easily can get off track. To have something written down can be a nice way of just orienting them. But here's an example of homework review, doing some kind of card game or internet search. That could be like psychoeducation, and again, choice is nice too. So you could do a card game or internet search, or let the child decide. Maybe they want to learn like a relaxation skill. So this is making you the expert on calming your body. So I think that giving choices around agendas is also good, as long as they're equally appropriate ones that you've established as the clinician. And then certainly building in, especially for kids, fun time, or maybe for adolescents, maybe it's just some talk time where they can spend the last 5 or 10 minutes talking about what they're going to be doing this weekend, or talking about their boyfriend or girlfriend or whatever. And then it's also important with the caregiver is to have an agenda, so it's very clear that when they come in that you have a set plan for them, and certainly get their input, and that collaborative aspect of treatment, which is what do they want to add. You can do the same thing with caregivers as we did with this youth. Is if they come in, maybe they came in really upset, you could they had been learning about the cognitive triangle, to just work that in with a parent as well. So it's very productive and useful. All right, so here I just wanted to go through a case example that to kind of maybe illustrate how with this family dealing with a lot of adversity and crisis, how evidence-based practice could be used. So this was a case. This isn't really the Curtis family. That's a made-up name. This is a real family, but all the identifying information has been changed or deleted. So there was a grandmother, a 9-year-old granddaughter, and a 10-year-old nephew that she was raising. And over 2 months, the intake therapist had probably talked to grandmother about 8 times, rescheduled several appointments. The grandmother, so there was a lot of, the children would come with a lot of traumatic losses. Actually, the whole family had been dealing with a lot of traumatic losses. The grandmother had lost her husband, and then also lost her sister and brother as well. And the granddaughter, the nephew had lost his parents, and the granddaughter was being raised by the grandmother because the parents were unable to take care of the child. There was a lot of substance abuse. So again, going back, a lot of multi-generational substance use. The caregiver had her own trauma history. I think this is very common that we find. So she grew up very poor, had experienced child sexual abuse. Her father abused alcohol. She experienced physical, sexual, and emotional abuse later in her life as a teenager, and then went on to marry an alcoholic who was also physically and emotionally abusive. There was, again, bringing up this issue of a lot of poverty over many generations. I should say the caregiver's own trauma history made it difficult for her to tolerate exposure to her the granddaughter and nephew's trauma without being sort of overwhelmed. And she also struggled a lot with organizational and problem-solving skills, which contributed to her feelings of being chronically overwhelmed. So she would try to keep track of her schedule by slipping reminder cards into her checkbook, but it would become very disordered and result in a lot of missed appointments, unpaid bills. There was a lot of resistance to talking about the father's death for the child, and a lot of confidentiality concerns. So again, this comes back to the previous dissatisfying mental health experience that they had. They had a distrust of mental health when they were coming to treatment, and had a lot of concerns about what would be shared and such. So just thinking about sort of what you would do, where my little scale went, but kind of want you just to think about, and I guess I can have people, I'm going to sort of go over, this is an example of TFCBT and how it was implemented flexibly with a lot of adversity and crisis. If you have thoughts as I'm talking, I would love to hear that, and if you could write those in as you did before when we first started the webinar, that would be great. So because of the nature of this this case, that really it was decided that there needed to be multiple therapists, that they kind of took a treatment team of, I don't realize this may not be entirely possible at organizations, but so treatment was provided by 3 therapists with a supervisor, and there was active collaboration among the therapists that they met weekly for coordination of care, again, with this family who had a lot of stressors, and I think it's easy for us to sort of, as clinicians, kind of take that on and feel very stressed, and I think having a treatment team approach helps to feel supported within your organization, and that you're not having to do it all on your own. And then the confidentiality issues were addressed by establishing trust and sort of setting, being clearly communicating with the family about, what was being shared, why it was important, or the rationale for why to share things among family members, but certainly getting permission to do so. And then this is kind of an example of an expansion of a component for some families, that there was a real need to intensify because the grandmother got really overwhelmed easily with the kids' behaviors, that there was an intensification of the parenting component needed, but then tailored it to her own personal style, so the clinicians would find that they would talk to her about, they would go over some parenting skill, and that she had kind of, over the course of the week, sort of put her own little spin on it, and so it invited her to talk about that and found a way to still have the skills stay the same, the objectives of the skills, but that she could use her own style with that. And then actively involving the caregiver in treatment, because considering the grandma's history and distress and her own history and the impact on her parenting and how she responded to the children, it was really imperative that the caregiver was actively involved in treatment. And then again, kind of just what we were talking about with cows, is that this, again, with dealing with a lot of poverty and her difficulties with, other system involvement, she had other children, sort of thing, who had some trouble with the law, that there was a portion of the session set aside for these real-life predicaments, which was really helpful. Still went through the TFCBT model, but allowed this caregiver to feel like those were being addressed, and I think in the process gave her some sense of feeling a little bit more efficacious. So with the organizational and problem-solving skills, the solution was to develop a strategy of making lists of things that she needed to do and wanted to say. And then role play was used within the session, so with the therapist and the grandmother, to practice appropriate communication skills in intimidating situations. So, and then she was able to practice those skills again outside the session she was able to overcome a fear of police that she had, and she was able to report some violent threats by her other son. And then she was also able to, through these communication skills, assert herself with social service agencies. So again, it's having those skills, practicing them in session, and then putting them to use in the real world, so to speak. All right. So did we get any? Did anybody write in anything? Okay. I don't know if people. One second. So what I'd like to do is, I really encourage you to reflect on what we've discussed today. You know, take a minute now to think about what is something that you could take away from what we've talked about and try to incorporate into your work. So, you know, maybe just 2 or 3 strategies or 2 or 3 kind of main points that you could apply when you're using evidence-based practices with families facing stress and adversity. I do want to get to questions, and I have an opportunity if people want to. We've got about, looks like 10 people on the call that we can unmute people. I know you've been in listen mode, and we can unmute and have people ask questions about anything I've said in the remaining, looks like we've got about 10 minutes. So be thinking about that. And, you know, as I want to just go over, I have some kind of housekeeping stuff that I would like to go over, not I need to, but would like to. And then I can unmute you guys and see if anybody has questions in the remaining time that we have together. So there's a survey we'd love that follows the completion of this webinar, and the link is there in your PowerPoint. I think we're also sending out a you'll also get an email with this link. It's not a real lengthy survey, but we really do appreciate it, and we've actually have appreciated the feedback we got from other participants, and we've been able to adjust and hopefully make changes. So we'd really love to hear from you. Also, I don't know how many of you have signed up for the consultation calls. We will be doing 3 consultation calls. You can see the dates there. They are coming up next month. So we've got a few weeks before we start them. They'll be at the same time, 11 to 12. And the purpose of and there's the call-in information. I'll be leading those calls, and I'll be sending kind of a welcome email out prior to the call. But just want to let you know that you know, a lot of you guys, when you wrote in sort of your kind of specific kind of for you, what kind of gets in the way, and to, you know, help sort of take the webinar, which is, you know, you realize it's one and a half hour faceless experience, and hopefully get a little bit more down in the weeds, if you will, with some of your cases and troubleshooting and problem solving and applying the things that we've talked about today to your specific cases where you're having some challenges. So I wanted to clarify in case people had, again, some different idea about the call, but really the purpose is to get as case specific as possible, because I really feel like that's where it allows some real learning to take place and some application. So I will be asking people to be bringing their cases to the call. I have a little brief format, kind of presentation format that you guys can follow as we're talking about cases, and then we'll really be focused on sort of, again, this idea of staying the course with EBPs while also dealing with some of these other stressors that families are bringing with. So if anybody has any questions, they can email me. My email address is on the last slide. It's right there. And we can also, I believe we can send it out with the email to the link as well. So if you have any questions about whether or not, you know, it would make sense for you to be on the calls, or if you want to talk to me more about it, I'm more than happy to do that. So that's all I wanted to say. So let's go ahead and try this. So there's 10, and I don't know how many of you are all sort of sitting together, but I'll unmute and see if anybody has any, hopefully, questions that I can address about anything that has come up today, or any questions about the consult calls. So does anybody have any questions that they would like to ask in the remaining time we have today? Hopefully I haven't woken you all from a nap. Hopefully I didn't put you all to sleep. Okay, well, certainly if there are no questions people have, then we can wrap up. I want to thank everybody for your participation today, and like I said, there's my email address. It'll come in another email as well if you have any questions. But I look forward to, for those of you who will be joining the consult calls, I'll look forward to talking to you, or look for an email from me in the coming weeks around that. Thanks, everybody, and enjoy the rest of your week.